Welcome to the Caribbean Institute of Oral and Maxillofacial Surgery and Implantology dental implant course, which has been running for 10 years, to be exact, today. 10 years with very positive outcome, untarnished image. As you will appreciate, the largest implant organization in the world, ICOI, actually 10 years ago, accredited my institute to carry out the function of training dentists in the field of implantology in the Caribbean and worldwide. A very delicate position that if you are not careful, you will not only get into trouble, but you'll get other people into trouble. And I want to congratulate myself and those who have been working with me for the past 10 years, that we've not gotten anybody into trouble, and we've not gotten ourselves into trouble. In fact, we have moved from A to B to C and jump from C to almost Z. And you will appreciate what I'm saying very soon. The journey has not been easy. And some of us here know what I mean. Because when I started teaching implantology 10 years ago, I was more or less attacked by the dental association here, the local association, that who am I doing dental implant courses? I have to do it under them. You know? But I have to do it under them. Of course, on the day that I was doing my first implant course in Montego Bay, the dental organization was having a meeting in Kingston, the dental fraternity, that we have to stop this guy because he's going to make our association look shabby. But, you know, if you are doing the right thing and you know the right word to say to people, they will leave you. You know, and one of the messages I sent to them was, my office and my organization is my private business. I can invite anybody who wants to come. I can tell them how much I want them to pay to come to my house to listen to me talk. You know, of course, they left me. And then 2-3 years after, they called me to a meeting which started around 8 o'clock in the evening and finished after midnight because I wasn't going to agree easily to what they wanted. What they wanted basically was for me to do these courses under their auspices and for them to be the one to be in control and tell me what to do, and for them to be in charge of the accreditation by ICOI. And, you know, it was a very, very delicate evening because I wasn't thinking of losing everything, but I was thinking that this thing that I am doing, that I have started, I don't think they could do it the way it has to be done. And I remember I went to the toilet. It must be around 11 o'clock in the night. I didn't want to use the toilet. But then I called Dr. Kenneth Judy that is the ICOI chairman, from the toilet. And I said, listen, they just want me to hand over this thing to them. And you know, you have to listen to the elders. He said, Chris, don't worry. Let them have it. Let them have it. But believe me, they can't handle it. They will take it and they will drop it automatically. So when I came back from the toilet, I said to them, you can have it. So they were shocked because I'm a very stubborn guy. And they were wondering, I mean, going to urinate will make a man change his mind. Huh? So I handed over to them. And they decided the date for the next course. I left them to organize everything. I got ICOI to get lecturers to come and this and that and that. They couldn't even get one delegate for themselves. So I said to them, it looked like you need more of my input. So I said, okay, we're going to reschedule this for December. So December, I got almost 20 delegates from all over the Caribbean. And we did it big. Remember, Dr. Zoh? We did it very big. And I let them appreciate that it was not money. They asked me how much, no, they should pay me. I said, no, I don't want anything. Keep the money. But then you go for meetings, you do this big thing, nothing in the newsletter that Ogunsalu did this, Ogunsalu did that. No thank you, nothing. I watched for 8 months. And then I called them. I said, you know what? You are not appreciative people. I'm going to commence my course the way I used to do it before. You can do yours. And, you know, and they did one at the Wyndham in Kingston. It was supposed to be a big thing. Tenax and some other company sponsored and so on and so forth. They had one delegate. They had one delegate. And of course, I can go on and say, but today, this course is being done all over the Caribbean. I've done courses in Bahamas, in St. Lucia, in Trinidad, name it. And the waiting list for dental associations waiting for me to come and do courses is so enormous. Uganda, Kenya, and, you know, Nigeria. And fortunately for Nigeria, I have secured sponsorship to do an implant course to sensitize the Nigerian community in June. And of course, this takes me to introduce you to the Nigerian High Commissioner, who today, this is Mr. Oyedele, and who today is our special guest. And, you know, he told me, he said he's going to be launching his book in Nigeria in June. Am I right, sir? And I said to myself, well, I have to be there. And the way for me to be there is to now set the date for the Nigeria implant course to be around the time that our goodly High Commissioner in Jamaica will be launching his book, so that I'll be there. and even make arrangement with him from now to be the special guest at the Nigeria dental implant course, which is going to be at the College of Medicine, University of Lagos. The dean emails me almost every day. She wants a date. They are scared that I will not come. But if they knew how to get in touch with Amin, Amin will tell them, he's going to come, don't worry. Not so. Yeah. You see, once I say I'm going to do, I'm going to do. Because before I say I'm going to do, I've known how I am going to do. Of course, I have instructed them specifically. I am coming to teach nothing less than a hall full of 200 dentists. And they're going to be coming from all over Nigeria. And at this time, we'll be launching the Lagos Dental Implant Organization. Because the Nigerian Dental Implant Organization was established some years ago. And just 2 months ago, I de-affiliated Nigerian Dental Implant Association from ICOI. And the reason why I de-affiliated them was that I gave them warning for 3 years that they had to do certain things. And their existence depended on my cooperation. Of course, I cooperated with them, but I could no longer cover up for them for all the negative and backward steps that they have taken. Not that Nigeria is not a lovely country. It's a lovely country. But like for example, Amin is here. He's from East Africa. I established East Africa section of the ICOI. And of course, there are certain drawbacks already. And I've been stylishly telling him that it has to be rectified. Because if it's not rectified, you see, my name is very, very important. You know, and everything that I do, I think about my name. You know, I don't cheat, I don't steal, all those things I don't do. So, after introducing our special guest, the next thing to do is to introduce everybody here, starting from Amin. Dr. Naji Amin is an ICOI diplomat. He got his diplomat certification just a few weeks ago in Kenya in an ICOI ceremony which I conducted on behalf of the ICOI. First time in the history of ICOI. Of course, when I told the people in Kenya that don't worry, you don't have to travel to America, I'm going to bring the ceremony to you, they thought I was joking. Of course, I did it, and it was all sponsored by ICOI. And we certified 9 fellows, 2 diplomats, 1 diplomat, and that was Amin being the first diplomat of the ICOI in East Africa, and 2 masters. And it brings me to what Amin is doing here today. You wonder what he's doing here. He's not a special guest. But as qualified as Amin is, being an ICOI diplomat, that is the most you can reach. That's the highest you can reach. He's here today because he's receiving additional training from me so that he himself can begin to conduct implant courses in East Africa. And at the end of this course, Amin will be certified as an instructor with both my signature and the signature of ICOI on his certificate that he can conduct implant courses anywhere in the world. But Dr. Amin, I'm going to ask you, concentrate on East Africa. Your focus must be to train everybody in East Africa. And let me tell you, I've done a lot in the Caribbean. And when I realized that was in 2003, when ICOI diverted the conference in Turkey to Ritz-Carlton, and they asked me to be the chairman of that conference. And all the dentists that came from the Caribbean were asked, who taught you implant? Everybody pointed at me. I was very happy. I never knew I'd done so much work. And that was when I realized that, and I said I'm going to do more. And I've trained even more and more after that. I congratulate you for what will soon happen for you. And in the presence of everybody here, I'm going to tell you, you have to be honest. You have to be disciplined. You have to be strict. Exam is exam. When you have exam for people, you don't give them questions, you can give them hints. And when you are doing courses, you have to be strict. Your main goal is for your delegates to understand what you are teaching. If they do not understand, and if they cannot do that procedure, it is your failure, not their failure. And I have Dr. Mama here, Judith Mama, from the U.S. I don't know which part of the U.S. New Jersey, yes. And, the ICOI chairman is in New Jersey. That is where he lives and his practice is there. I'm going to introduce you to him. And you are going to have another mentor apart from me. You'll be able to walk into his office and watch procedures and advance yourself. Because Dr. Kenneth Judy and myself, as popular as he is and as great as he is, we are buddies. I call him any time of the day. And we meet in places. We have our places where we meet. And in fact, just December, we had a lovely dinner at a very posh restaurant in New York. The dinner started at 7 o'clock, and we did not finish until around to midnight. We must have had about 14 different courses. I was counting it. We were drinking. And it was all the gurus of implantology in the world. And, it was very nice to be the only black guy there and to be the youngest amongst all of them. Dr. Max Zand from Boston. And, he showed his intention to attend this course through his friend who had attended this course in January. And through email, I realized that, this guy really, really, really wants to do implantology. And everything he asked me to do for him to be able to attend this course, I did it. Everything, I did it. And he understands. And only today, I said to him, he said to me, Doc, I want to do residency in oral and maxillofacial surgery. And I said to him, don't worry, you will get in. If you do very well on this course, remember I said that to you, huh? If you do very well on this course, you can use my name as referee. And once they see my name, they'll take you. Because, you see, my reference is very difficult, and people know that. I mean, a lot of people will ask me for a referee, and I'll say to them, I'm sorry, I can't give you. And the reason is I have nothing nice to write. But once I say I'm going to give you, just know that it's something great. And of course, even in Boston there, I have colleagues that we sit on the council of the International College of Dentists together, and who are in charge of residency programs and so on and so forth. So if you want me to give you a reference, you have to do very well on this course. All right? Not just, hands-on this and the written exam. So you have to work very hard. And that's why when I told your girlfriend yesterday that from today, she won't see you. She won't see you because, and Dr. Mama, you won't have any time for your husband. He's here, right? Yeah. Yeah. You won't have any time for him until the course finishes because it's very comprehensive. It is the syllabus of a 1-year MSc course that I am doing in 6 days, plus the 21 days you've been having. Dr. Windsor, my great friend, my very, very good friend. Zor probably knows me better than any Jamaican dentist. Zor is from Burma. Zor is probably the next person in line to me in Montego Bay doing implants and doing them comfortably without any problems. And I trained Zor 10 years ago, sir? 7 years ago. 7 years ago. And when I invited Zor, he was very pessimistic. I can't do this thing. I can't do this thing, I said, don't worry, Dr. Zor. I'll make sure you can do it. And, today, even my patients will go to him. It's not a problem. That is my pride. That is my pride, that the person I taught, my own patients can go to him. It tells me that I am successful. And after watching what he's been doing for years, I invited him in the same capacity as Dr. Ami. And hopefully Dr. Zor will be conducting courses in Burma, his own native country. And I've told him he wants to conduct implant courses in the Caribbean, in Jamaica, in Montego Bay. You're welcome. You see, at least when I die, I have left people behind to do things that I'm doing. So I'm not really scared, except for the fact that I have little kids, which they want me to see them a little further. And then I've been telling this gentleman from Nigeria, and I will briefly tell you the challenges that he had for coming here. I've been telling him he's the only hope of Nigeria for implantology, but he does not understand me. You see, what you did is not ordinary. In that, he met me in Mombasa, Kenya, after the sensitization course, insisted that he was coming to the Caribbean for the implant course. I said to him, no, you can't come to Caribbean. Stay in Nigeria, wait, I will soon come and teach all of you. He said, no, he's not waiting, he's coming. I tried to convince him not to come, but he said he's coming. I gave him the form and everything, he filled it. And 5,000 US for a Nigerian to pay for a course is a challenge. He must have sold a lot of things. How many cows did you sell? He must have sold a lot of things. And he, at the last minute, Trinidad, because he was supposed to attend the December course in Trinidad, they denied him visa. And he was so disappointed. I could understand what was going on in his mind. He knew that because it's a limited attendance course, his not getting visa is his problem. And probably has forfeited his money. And couldn't even communicate with me after he told me that he didn't get his visa. He was scared to hear the worst. I knew. He was scared to hear that he has forfeited his money. But after the course, shortly before Christmas, I called him. I said, listen, see if you can get Jamaica visa. I'm putting you on the course that I am coordinating with another guy from the US in January. He tried, he got Jamaica visa, but was denied UK transit visa. And then I emailed him again and said, okay, I'm going to put you in the April course. This time, don't go to UK embassy. Travel through Germany. And that is how he's here today. And, he was privileged. I didn't know he was arriving like almost 1 week earlier than the others and before the course started. So he was privileged. I'm telling everybody because I don't cheat, He was privileged to be able to attend the cadaver session for the instructors. So the cadaver session that was designed for Dr. Zor and Dr. Amin, he also attended it. So it's probably at a more higher level than the others, but I'm going to bring all of you up similarly because you're going to do the cadaver session also. It's just like he'll be doing it the second time. And I will give you the double credit, because that is what you deserve. And I hope as you get back, you set up your implant practice, even if you have to sell your house and rent a room somewhere, then you should just go ahead. And you'll be okay. And that brings me to what Mr. Ramsey is doing here. Mr. Ramsey is going to be doing the audiovisual for all the lectures that I am doing today. And that brings us to what item number 6 is, which is launching of the e-book, Teach Yourself Implantology by Dr. Ogunsalu. So I'm not going to talk about it now. But, in another 2 months, if Dr. Max Zand had not attended this course, for example, he will be able to buy this e-book. Sit down in Boston. Put it on in his office, in his house, and listen to my lecture. He's watching me lecturing just like he's watching me lecturing here. And that is the next level that I've taken this. And this is going to be formally launched again at the ICOI meeting in New Orleans on the 22nd of this month. And the reason is, I see that a lot of people throughout the world, dentists throughout the world, want to learn implantology. But the electronic world has not allowed them to be able to do so, even though it is electronic world. And because of my position I am able to do this, and my vision. And of course, I should have launched this longer than this or earlier than this. But almost a year ago, when I gave the audiovisual tapes and so on and so forth to Mr. Ramsey, he looked at them and he said to me, they are of poor quality. I had done this recording in Trinidad about 2 years ago. But according to Mr. Ramsey, he told me that they are poor quality. And, you know, I know where Mr. Ramsey is coming from. Mr. Ramsey works at the University of the West Indies. And these are trained people in the area of information technology. I didn't even challenge him. I just said to him, would you be able to do another one for me at the next course? And that is why he's here. And he's going to be doing audiovisual of all the lectures, audiovisual of the lab hands-on, both restorative and surgical, audiovisual of all the cases. And let me tell you, you are going to watch all the cases in implantology, everything you're going to come through. Delivery of restoration, implant surgery itself, single, multiple, implant patch-up, you know, what I call patch-up, when you put 2 implants or 3 implants and you have to connect it to a tooth and do cantilever and this and that. Yeah. You're going to watch difficult second-stage surgery. You're going to watch simple second-stage surgery. You're going to watch impression taking. You're going to watch consultation, how to talk to patients. And this gentleman witnessed something in his visit. You know, I moved from Market Street. February 2nd to my own building, which is in a residential area. And I have no sign there, just number 52. And I'm always very busy. The patients find me. And he sees that in the supermarket, every supermarket I went, I had to be giving patient appointments in the supermarket for implants and so on and so forth. And, you know, I've reached a stage in my life where professionally, you know, I feel fulfilled. But at the same time, I want to try for my other colleagues, for them to reach a level which will make them very happy. Maxan said something to me this morning, and it moved me. And, you know, I realized he's a wise guy. He said to me, general dentistry is no longer challenging to him. He's fed up of doing fillings and this and that and that. And is he a person like that? Will be taught implantology, and within 2 years, he's just cleaning out the place. Implants. So, you're all welcome. And at this stage, I want to, so I've done item 1 and 2 together, so I'm going to invite Ambassador Peter Oyedele, our Nigerian High Commissioner, who is our special guest today, to make an opening speech. Now, of course, we do have press coverage. It's just that they are not here, but we have an understanding that we will email information to them and so on and so forth, and so that our ambassador's opening speech is very, very important. You know, the things that will make a country proud, basically, is when their image is being lighted positively. And a lot of Nigerians here have been doing that. And, the e-book, this is the first time in the history of implantology that there will be a complete e-book. And I suspect the first time in the world that there will be an e-book, Teach Yourself. Of course, if Dr. Mama buys the book, she cannot sell it to Dr. I'm going to lock it. And I'm also going to do something that once you use it once, for you to be able to use it again, you probably get our permission or something like that. But we'll see how it goes.
Dr. Ogunshalu, distinguished course participants, I say good morning to all of you. Well, it's a great pleasure being invited to a course of this nature and this dimension. I didn't quite know much about this, the organization of this course, when Dr. Ogunshalu spoke to me and invited me. He first called me, he left a voicemail for me, and when I heard, I said, okay, well, I was trying to trace him because, when you leave the voicemail, the number does not show. There was no way I could call him back. Then I phoned someone in Mantugu. I said, well, do you know so-so? He said, yes, please tell him that I got this message, but I don't know how to reach him. They gave him the message, then he said he was coming. I think the same day, he just walked into my office and said, well, he had come personally to invite me to this program. Well, it's not long that I knew Dr. Ogunshalu, and that's because I've not been long here too. If I had been here in the Caribbean for a couple of years, I'm sure we would have known each other long before now. It's just a couple of months ago that we met. It was a Nigerian student here who was graduating. I think he got his doctorate in mathematics. He was leaving and came to say goodbye to me and told me about him. I said, well, I've never heard about this gentleman you are talking about. Then he said, okay, he will bring him to my office. And he did. That was the first time we knew each other. And since then, I had met a lot of people who were talking about him. I said, look, how come I did not know about him until this man brought him to my office and introduced him to me? Well, I think Dr. Ogunshalu has been in this region for about 20 years now. It's quite a long while. And, well, he knows the area very well, and the people know him very, very well. Well, we were all listening attentively when he was telling us the problems he had initially when he set up this institute. Well, anything that you succeed in life definitely must run into obstacles at the onset. So if you remain undaunted and you're sure of your goal, well, you continue to soldier on. And I think that is why he has achieved this success so far. If he had given in, or he had become timid, and did not stand his ground, I'm quite sure that, well, this institute wouldn't have achieved this success. So first I want to congratulate him on a job very well done. Well, as a Nigerian, I'm proud that my compatriot is doing a thing like this in Jamaica, in the Caribbean. I'm however happy that he's well known too in Nigeria, because he's been invited to this and that. He told me what he tried to do at University of Ibadan, how some people messed it up. He was not happy about it. And I think when he was talking to us, he says he had declassified it or did something about it. So, well, he's been invited to Luth, College of Medicine in June, as you heard him say. I hope that exercise will be a successful one. And I'll be in Nigeria around that time, God willing. And definitely I'll be able to attend the opening of the session that he's going to conduct in Lagos. So, well, I think I'm the only strange bedfellow here because I don't know much about your field. You all are experts, and that's why you have been invited to participate effectively. Mine is just to state how happy I am to be here and to see the good work that Dr. Gushalu is doing. And, well, since he's already well known in Nigeria, and wherever we can spread the news about his activities here, definitely we shall do so. Well, I believe maybe my government knows about him, but if not, definitely since I know, I must report on this visit to my government and to say exactly what I've seen. I've seen US experts coming from virtually all, from many parts of the world. Dr. Chukwu, who met me at the gate, when I asked him, I said, yes. When I had I said, definitely you're in Nigeria. I said, yes. Where are you from? I said, Jos? You came all the way from Jos? Believe me, I was surprised. Then I got in here too. Dr. Amin, am I right? Where are you from? Kenya. The same Kenya. Then I said, Abari. You know, that's the way you greet. You say Missouri. Then we say, have you ever been to East Africa? Oh, yes. I said, I served there as a young diplomat. And I enjoyed my stay there a lot. Nairobi, Kenya generally was a country I really enjoyed working in. And, of course, we discussed a lot and tried to revive old memories. In any case, then another Nigerian also, Dr. Momo from New Jersey. Apparently my children live in New Jersey. So she's here, and all the other doctors that are here for this course. It's an intensive course from what I've seen on this program. And as Dr. Gushalu himself said, maybe you find it difficult to spend some time, except at night, with your friends or spouses. But in any case, with a sacrifice that you have made up your mind to make, and I'm sure you'll make success of it. So, Dr. Gushalu, you are doing a good job. I commend you, and I'm very, very proud of you. Very proud of you. Very proud of your achievements. And a lot of people have passed through your hands, and I know many more will still pass through your hands. It's not time for you to go yet. Your children must have graduated and even occupied the position before you leave. So don't talk about quitting now. You still have a long to go at your age. God has blessed you. You started very early, and to have reached this stage in your life, I think it's something commendable and something which you personally have to be proud of. So I want to say that, well, we are proud of your work. I want to advise you to still continue to do this good work, which is for humanity. We're all benefiting from it. You're serving humanity. And that's why even my doctor's son, I have my son who's a doctor, but he's not a dentist, he's a pediatrician. He works in Chicago. So when I told him, why do you want to go do medicine? Well, he said, feels since his sister refused to read medicine, he said he wanted to take it as a challenge and feel that it's a service to humanity. I said, at your age, you know that we need to serve humanity. Okay, go ahead. So thank God, I think he's doing fine in that field. So, well, your area of specialty too is very, very important. And we appreciate you people who undertake training in this field. I just came back from Belize, and I visited the hospital in a place they call Punta Gorda. Well, it's in the north or so of Belize, about 3 or 4 hours drive from Belize City. From Bemupan. Bemupan is, I don't know whether you're familiar with this part of the world. So I went to the hospital. Well, one of the part of the program arranged for me was a visit to the hospital there. Believe me, you must be someone who has a big heart to work in a hospital. Some emergency cases were brought in my presence, and believe me, I just say, well, and people, I said, people attend to all this, they have the courage, you know. I mean, your job, it's really a very, very difficult one for us, the laymen. So, but, well, you have chosen the career, and you are doing well in it. So, I pray that you continue to do well, and that your course here will be fruitful to you when you go back to your various places of work. Now, about visa for Dr. Chukwu, well, it's a big problem for many Nigerians coming to this part of the world. And I've been taking it up with the Jamaican authorities. You see, you know, between here and Lagos, Kingston, Lagos is just 8 hours flight. Just 8 hours. But now, you have to go either through the UK or the United States to get to Nigeria. In which case, you have to make about 2 days on the way. Because sometimes you may not get immediate connecting flight. You have to pass the night somewhere. And then, you know, you continue the next day. So I've been meeting the Jamaican authorities about this. And I hope before I leave here, I'll be able to succeed to persuade them. Because we have Nigerian airlines that are ready to fly the route. And I know it will be profitable if it's well advertised, because we have many Nigerians in this part of the world. Many of them will be coming to Kingston or anywhere to catch the flight. Even Nigerians living in the U.S., in Florida, and Atlanta. It will be much easier for them and cheaper. It will be cheaper for them to come here to catch a flight straight to Lagos which will last only 8 hours, and that's the distance between the U.S. and Britain or London. So for them to fly straight to Nigeria from here, I'm sure it's something they will appreciate. And if the publicity is well handled, a lot of people will be aware of it, and I know the route will be profitable. So we're still working on it. Unfortunately, the problem with Air Jamaica, you know, is a big constraint. If Air Jamaica had been, you know, doing well, perhaps our discussion would have gone further than this. But, well, some of you don't know much about the local problem here. Air Jamaica has problem, debt problem, and so on. They want to sell it off. And so I think this month, the Caribbean Airlines will take it over. So, well, maybe this is really a matter that has sort of slowed down our negotiation. So in any case, we'll still see what we can do to make people like Dr. Chukwu, who wants to come here, to make it easier for them. And there'll be a lot of interaction between Nigeria and Jamaica. I was telling the tourism minister, there are many, many rich Nigerians who would like to come here when they know they can fly straight here, come to Negri, come to Tigo Bay and all this, because they've been hearing about those beaches, lovely holiday resorts. And they'll be coming, even having their weddings here. Because I know many Nigerians living in the US come to Jamaica for weddings and other ceremonies. You see, because there are lovely beaches here. And people, you know, who have the means, they come, enjoy. So, well, if we have this flight, I'm quite positive that a lot of Nigerians will be coming here. And even businessmen, a lot of trade will flow between the two countries. And again, of course, you can have student exchange. And that will make it easier for the youth of both countries to know each other better. So all these things, you know, are some of the advantages we may derive from the direct flights if they're introduced. So once again, let me say tell you once again how happy I am to be here and how honored I am. I want to thank you, Dr. Gushanlu, for this invitation, which I cherish a lot. And I will come to pray for you that that you come to succeed in your activities. And for those of you that have come from near and afar, I wish you safe journey back at the end of this training. Thank you. God bless you.
Thank you, Sir Ambassador Oyedele. I'm very happy that you're here today with us. And I know that there are a lot that you can do for us here, for Nigeria here. And what you just mentioned about the flight to Nigeria is very, very important. And in fact, if we have such a thing, just believe it. I think I'll be going to Nigeria every 2 weeks. Huh? So you can tell them already that I will be going to Nigeria every 2 weeks, because it's like going to Kingston and coming back. So I'll be going every two weeks. And more grease on your elbow. And in fact, I've been to Belize in 1996. And then the International College of Dentists, of which I happen to be a councilman, and my region is the whole of the English-speaking Caribbean. I'm in charge of the whole of the English-speaking Caribbean, Belize, Bermuda, Guyana, and which other country now? Bahamas. That is my territory. And in fact, the Governor General, you must have met him, Dr. Young.
Yes.
Yes. They invited me last year, and I was unable to go. But I'll probably be going before the end of this year, because I told them I will still make it, you know. And I will let you know the nature of my visit there. Now, dental implant education in the Caribbean. Where are we now? Basically, we have moved from where one person was the only one doing implants to where so many are doing implants. And of course, the only person who was doing implant then in Jamaica, you know, when I now started doing and teaching, he pulled me aside and he said, "Chris, why are you doing this? This is supposed to be the bread and butter of you and me. Why are you letting the general dentists know about this? You know, you should let them stay in their office and just clean their patients' teeth and fill teeth." So I looked at him. I won't mention his name, but if you had Jamaica dentists here, you will know who. So I said to him, I said, so and so, is that how you think about your own colleagues? And basically, you know, his comment really, really made me very upset. And I was determined that I was not going to stop. I was going to teach the Caribbean dentists. And today, I can say to you, in Trinidad, I must have trained over 100 dentists who are now doing implants. The guru of implantology in Bahamas passed through me, Dr. Kendall Major. The guru of implantology in Antigua, who he now does courses, he's now actually he sits on the same accreditation committee in the ICOI with me. Although he got there behind my back. But I never cut him down because I was happy that somebody I created was going to sit there. So he also was trained and accredited by me years ago. And also, almost everybody in Jamaica doing implantology today were trained by me, except one or two, one of which was the one who was against me teaching implantology because he wanted everything for himself. And I can mention other Caribbean islands, and you have implantologists that have passed through me and been trained by me. So that is where we are. And everybody are actively practicing implantology. I plan to host a Caribbean dental implant conference, a large conference. I won't have the energy to do it next year, but 2012, I will do it. And we will do it very big, very, very big. With probably 100 exhibitors from all over the world. And I'm actually waiting for the convention center. Now, as you will see, the electronic book has the e-distant learning component that is in that folder. And the residential component. And then it has the cadaver manual. So the electronic book has the 21 days e-distant learning folder. So you have everything there. So you can open distant learning 1, for example. So the distant learning 1, you read it, you do your assignment. You can open any one, you know. And it also has distant learning 1. You can go into, probably double click and, All right. So those are your instructions for distant learning 1. And then you do your assignments and so on. So those of you who have been doing your assignments, you know what we're talking about. So we can go back and go back. And of course we have tutorials and then we have literature review. You don't have to open. And then go back. So we have the residential course component, which we're starting today. And you have day 1, day 2, day 3, day 4, day 5, day 6. Open day 1. So all the lectures we're going to do on day 1. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 lectures. Everything is in PowerPoint, is in that folder. So you will not only read this, but you will have an audio visual of me so that, you really don't have to have come. Okay? Back. And you have day 2, day 3. And day 3 is very difficult. Day 3 is about 22 lectures. And I just go on very, very fast. And Dr. Amin will tell you, I'm a what? What am I? And a serial killer. You see, they were shocked when I did implant on 9 patients. We started 8 o'clock in the morning, we finished about 3, 4 o'clock. 9 patients in Kenya. Nice, lovely. This is how I work. I don't work Monday, Tuesday, Wednesday, Thursday. I don't do surgery like that. I do surgery one day, or 2 days a week. And then I do other things during the other. I see my colleagues, they're lecturing on campus, rush to their clinic and then come back. I can't do that. I mean, I've done that before. I can't do it. Huh? It doesn't make what you are doing good. Huh? And everything is there. Including, go back, we're going to introduce you to experimental methods, how to design experiments, how to do experiments, and how to publish them, if that is what you want to do. And go back. And then in the residential course, for the cadaver session, which is the 6th day, you also have the cadaver manual. And what we did, open cadaver session, what we did is that for the cadaver session, of course, I'm going to have a human head for each of you. I'm going to give you a human head. And you will do all these procedures. You do them. What I did is go again, and for the first time in the world, nobody has ever done cadaver session like this. And this is, I divide it into 10 parts. Placement of implant, transmucosally, conventional implants, which is integral or endopore or pit easy, and then immediate implant. So all this you will do on the cadaver. So that is part 1 procedure. If you don't do them, I can't assign you. Part 2 procedure, mini implants. You will place them on cadaver for me. Go up. Or go down rather. And then part 3 procedure, we're going to do particularly bone grafting using bone scraper. I'm going to provide you with everything you need, all the materials we've set up for you. From the maxillary tuberosity, from the symphysis, everything. In fact, you are already doing your residency. You know that, huh? And they will have very little to teach you by the time I finish with you. You agree with me? Yeah. And then you will do minimally invasive sinus lift procedure, which is part 4 procedure. And then you will do part 5 procedure, which is block grafting. Subnasal augmentation. Part 6 procedure. Part 7 procedure, peri-implant bone grafting. Go on. Part 8 procedure, conventional sinus lift. 9, ridge augmentation and socket bone grafting. And then tibial tuberosity bone grafting. And iliac crest bone grafting. Now, go back, close that, and then go back. Each has its manual. Go to part 1. So these are the manuals you're going to follow. Go to that, and then PowerPoint. You see, I don't believe in textbooks. It's a waste of time. Huh? People don't have time to read textbook now. So this is how you're going to follow and do your procedure. So we're going to put everything on the screen for you. You're going to, and then because Mr. Ramsey has shoot the cadaver session for us, you're going to sit down and watch. Previously, early in the morning, I will go through it, and then you will now follow. But we're going to do better for you this time. And I can see Dr. Mama is looking excited already, despite the fact that Dr. Mama has been doing implantology before she came here. You see, you won't get all this from any course you will attend anywhere in the world. You won't. And the reason why you're getting it from me is because one Sunday morning, I just sat down. It was in 2003. Just sat down on my dining table in Trinidad. And I felt very upset that all the knowledge that I gained in implantology, if we add it up together, basically I'm not an idiot, I'm not a fool. Somebody could have taught me all this when I left dental school in just 1 month, and I will have built up on my own after that. And then people teach you little things and charge you big money. And I sat down and I started writing down all the courses I have attended throughout the world in sequence and what I benefited from them and the shortfalls from them. Add things together, subtract things. And I came up with the mini residency course. And I launched the mini residency course in 2003, or was it 2004, at the ICOI meeting at the Bellagio Hotel in Las Vegas. And all my colleagues on the accreditation committee were like, Chris, this is comprehensive. Do you have a patent on it? Of course. They're telling me that they want to copy it too. But I said to them, I don't need a patent on it. If this is how you want to teach your students, that is what I want. You understand what I'm saying to you? So that a lot of them have changed their so-called 1-year course to now 6 weeks, intermittent, alternate weeks, But I'm doing it in 6 days, plus 21 days distant learning. To end my speech on this matter and to officially launch my electronic book by giving Dr. Chukwu, Dr. Mark Zand, Dr. Mama, and Dr. Henry Emerson a copy because they are initial delegates. I want to say to all of you that, I envy all of you. I envy you because you are getting something that nobody could give me when I wanted it. I wanted to learn implantology from I came out of dental school in 1987. And in fact, I worked with the gurus in London. But they treated us as if we are autistic people. They don't talk to us. They just give us a camera sometimes to take picture for them. And they don't even tell us. They don't even tell us what they are doing. They're just doing it. And, it was 3 of us at King's College London then. 2 Brazilians. And they are twins. They paid a lot of money to do MSc at King's College London. And today, the 2 of them are gurus in implantology in Brazil and also guru in distraction osteogenesis, an area which I know very little or nothing on. Because I guess I really don't want to know, And it will have been an added asset. So Dr. Chukwu, because of the long journey, camera picture, the long journey that it took you to get here. You'll be the first person. And then Dr. Max Zahn.
Congratulations and good luck to you.
And then Dr. Mama.
Thank you.
Well, congratulations, good luck to you.
Thank you.
Nice to meet you here in Kingston.
Okay.
Okay.
Thank you. I have about 48 hours or so more work on the ebook to correct some typographical error and do some more editing, and then I will be putting the streamlined product together with it, so that I still have to give you something, so that the four of you will receive a flash drive from me very soon for the audiovisual and the edited version. And of course, for the instructors to be, they'll be receiving more information, which will even include exam questions and answers and so on and so forth. And this is where it is very important for you to maintain your integrity. I mean, historically, my exams have been very reasonable, but extremely difficult. Very reasonable, but extremely difficult, as Amin will tell you. I mean, if you score 10 over 25, I congratulate you and I think you're good. And don't be surprised if you score -5 over 25. It does happen. And so that when I release these questions to you, I don't want my delegates to be scoring 25 over 25. Huh? No matter how close you are to anybody, you cannot release it to them. You see, the exam is actually a teaching exercise, because none of you will know each other's mark. I mark them individually in your presence. And when I wrong it for you, immediately you know you are wrong. You don't even argue. You know you are wrong. You know? And I tell you the answer. I tell you why you're wrong. I tell you, you know. So you're learning. You're learning. So nobody will know your mark. I mean, I've tested it among professors of restorative dentistry, professor of oral and maxillofacial surgery, and some of them score -1, and so on and so forth. So that if you score 10, you're good. You understand what I'm saying to you? The most important thing is not to guess. So, we were expecting the Minister of Tourism, but the communication was not smooth. I mean, I met with him personally. He said he was going to come, but then the personal assistant did not communicate with me much, and I myself fell back in that I should have persisted and called more and so on and so forth. But I know during the course of the week, he will send us his message. He's a very nice gentleman, and this is what he likes. He likes education and tourism. He likes it. And basically, this is what we're doing. So before we say the vote of thanks or what have you, I'm going to start our lecture for today and give you 2 lectures. And then we'll say the vote of thanks, we'll take a little break and walk out and come back in. So let's go to residential course. So we're going to start now with bone physiology and bone biochemistry, the so-called bone biology. Bone is a living tissue that serves 2 primary functions. The function of structural support and the function of calcium metabolism. The coordinated action of the osteoclast and the osteoblast assist in the formation and resorption of bone. And as you all know from your undergraduate, osteoclasts are the cells that eat up bone, whereas osteoblasts are the cells that build up bone. And it is a coordinated action of both the osteoblast and osteoclast that ends up forming the bone that we desire to build up the ridge for the implants. As such, the formation of bone is a dynamic process involving building and resorption of bone. Let us look at the bone matrix. Bone matrix is composed of an extremely complex network of collagen protein fibers impregnated with minimal salt, and this includes calcium phosphate, calcium carbonate, calcium fluoride, magnesium fluoride, and in the different percentages that I have shown. The mineral in the bone are present in form of hydroxyapatite primarily. Okay. Bone also consists of small amount of non-collagen protein embedded in its mineral matrix, including the all-important family of bone morphogenic protein. And today, I can brag and tell you that one of the pioneers and the main guys in research relating to bone morphogenic protein, the late Dr. Philip Boyne, was somebody that I had personal contact with and was always very happy to receive me at the American College of Oral and Maxillofacial Conference meetings yearly. Bone is supplied with a rich vascular network that perfuse the viable cell as well as the network of nerves. To maintain normal bone structure, sufficient amount of protein and mineral must be present. The skull and the jawbone are unquestionably affected by the physiological and pathological state of other bones in the body. In other words, when you have a metabolic condition affecting the leg, it will most likely also affect the jawbone. An example is the Brown's tumor of hyperparathyroidism, which basically is the eating up of bone tissue. Now, it is for this reason that dentists placing osseointegrated implant should have a good understanding of bone structure and metabolism. The process of osseointegration of implant with graft should also be well known. And today, a lot of dentists place implant and they talk about osseointegration, but they don't understand what osseointegration means. Because they believe that osseointegration is what you see on the X-ray. But that is not. Osseointegration is more than what you see on the X-ray. And as you will find out from the literature and from the internet and from PubMed, my work on osseointegration of implants has even shown scientists that the only way you can assess osseointegration is by osteoblastic activity or osteoblastic index. And this was the basis of my PhD research work over the last 6 years. These are the cells that are involved in bone formation: the osteoblast, the osteocytes, and the osteoclast. Everybody knows the work of the osteoblast. It lays down bone. Everybody knows the work of the osteocytes. I mean, the osteoclast. It eats up bone. And everybody says the osteocyte is resting. But believe it, when I was a student, an undergraduate student, and they told me osteocytes are resting bone cells, I said to myself, it could never be resting. And today, there are research that have been conducted that now confirms that the osteocytes, although they look like they are resting, but they are sending signals to the osteoblast and the osteoclast. So they are the boss. They are sending signals, and that is their work. So they are not resting cells because their head or their brain is working. The osteoblast is involved in building the bone, and they are located in two areas: endosteal osteoblast and periosteal osteoblast. The endosteal osteoblasts are the osteoblasts that you see inside the bone itself, and the periosteal osteoblasts are the osteoblasts that are located within the periosteum. And that is why your periosteum is very important in implant surgery. Next. During osteogenesis, the osteoblasts select growth factors, including the transforming growth factor beta, TGF beta, no? Not TGI Friday, right? TGF beta, platelet-derived growth factors, and insulin-like growth factors, which are all stored in the bone matrix. Next. When osteoblasts successfully form bone matrix, they then become embedded in it and transformed into osteocytes, which happens to be the most abundant cell in the bone. They are characteristic as they communicate with each other and with cells on the bone surface via dendritic process housed in canaliculi. They have slightly basophilic cytoplasm. Now, regardless of the advancing calcification, the osteoblasts always remain alive. They express TGF beta and possibly other bone growth factors. The osteoclasts are the cells responsible for bone resorption, and they are under the control of the parathyroid hormones. They are fused monocytes that histologically appear as large multinucleated cells containing as many as 50 nucleus. They are located in shallow evacuations or the horsewhip lacunae along the mineralized bone surface. Let us look at bone metabolism. And, don't be surprised if I say to you that I can draw the structure of all these. 1,25-dihydroxycholecalciferol, which is actually intimately involved in bone metabolism and in the formation of calcium. parathyroid hormone, calcitonin, and other chemical agents. Now, 3 different processes are associated with successful bone grafting. But before I make mention of these 3 different processes, let me elaborate more on the cholecalciferol. The 1,25-dihydroxycholecalciferol actually started its journey from cholecalciferol, which you find on the skin and by the action of the sunlight and hydroxylation in the 25 position in the kidney becomes 25-hydroxycholecalciferol. And then it now undergoes a second hydroxylation in the liver in the number 1 position, and then it becomes 1-alpha-25-dihydroxycholecalciferol. And this agent, which is an hormone, increases the absorption of calcium in the stomach. It also increases the absorption of calcium in the kidney. And the parathyroid hormone also behaves similarly. Okay? Now, when you have, now what the parathyroid hormone actually does, although it increases the calcium level, just like 1,25-hydroxycholecalciferol increases the calcium level, but through a different mechanism. Its own mechanism is to eat up the bone and release calcium. So that the 2 of them, they end up increasing the calcium level. Whereas calcitonin brings back the calcium from the blood and builds up back the bone. And that is why the treatment of Brown's tumor of hyperparathyroidism is calcitonin. You give them calcitonin. No surgery is needed. Now, the 3 mechanisms of bone formation: osteogenesis, osteoinduction, and osteoconduction. And I want you to listen to this very well. Now, all bone grafting material possess 1 or 2 or 3 of these. Osteogenesis, this is the formation and development of bone. Osteogenic grafts are composed of cells involved in natural growth or repair of bone. These osteogenic cells encourages bone formation in soft tissue, or they may activate more speedy bone growth in bone sites. Osteoinduction is the process of stimulating or initiating osteogenesis. In other words, they themselves, this action is not forming bone on its own like autogenous bone, but it is going to stimulate the environment and encourage the environment to form bone. Osteoinductive grafts enhance bone regeneration and may even cause bone to grow in an area where it is not normally found. So that if I take an osteoinductive bone grafting material and I put it in an area where bone does not form, normally it will form bone. Similarly, if I put an osteogenic bone grafting material, which is going to be like your autogenous bone, if I take your autogenous bone and I put it in your liver, it's going to form bone because it is osteogenic. So this is my explanation of these mechanisms to you. And the laziest of these mechanisms is osteoconduction, which is a process which provides a physical matrix or scaffold suitable for the deposition of new bone. And let me tell you, osteoinductive osteogenic and osteoconductive bone grafting mechanisms are all positive bone grafting mechanisms. And in the past, scientists have shied away from recognizing the existence of a negative bone grafting mechanism, which is called osteoobstruction. This osteoobstructive bone mechanism was coincidentally discovered by me during my PhD research work over the last 3 or 4 years, which is called osteoobstruction. We're trying to call it Ogunsalu osteoobstructive mechanism. And we have presented a paper on it in Dubai this year, and the same paper has been accepted by a mathematical conference in Alaska, where we are trying to let people realize that we can determine these things by mathematical model. And this was one of my reasons for collaborating with Dr. Festus Arunaye. And the same osteoobstruction has been presented at a conference last year, American College of Oral and Maxillofacial Surgeons, with great ovation. And in fact, the mathematical modeling relating to it is going to be presented this month in San Antonio, Texas, at the American College of Oral and Maxillofacial Surgeons. They are really anxious and they want to listen to what I have to say on mathematical modeling for osteoobstruction. Now, the osteoconductive grafts are conductive to bone growth and allow bone apposition from existing bone, but they do not produce bone formation themselves when placed in soft tissue. Next. Osteoconductive grafts therefore need existing bone or differentiated mesenchymal cells. And you know, you will never see me use demineralized freeze-dry bone. Even if you give it to me as a present and you store it in my office, I won't use it for my patient. Because I'm very impatient, and I need to see results right now. And osteoconductive bone grafting material, such as demineralized freeze-dry bone, is going to try my patients. So I'm going to use synthetic bone graft, I'm going to use biols and so on and so forth, which will give me good results. Now, let us look at autogenous bone graft. It is an organic material that is harvested from the patient. And this is why I'm going to teach you how to harvest this from your patient very easy. Show you how to use the bone scraper so that you are not drilling and this and that and that and that, you know, and you get good amount of bone grafting material for your patient. It forms new bone by osteogenesis, osteoinduction, and osteoconduction. And I know you are all confused now because I am saying to you that it forms bone by all the three different mechanisms. And it is common sense. It forms bone primarily by way of osteogenesis. But because it is staying there and it is powerful, it can command cells in its surrounding to form into bone-forming cells. So it is also osteoinductive. And because it is keeping a space and maintaining a space for bone formation, it is osteoconductive. So it is the only bone grafting material that has all the three mechanisms. Next. And then allograft, harvested from cadaver, whether cortical or cancellous, have osteoconductive role primarily and possibly osteoinductive properties. And that is why some manufacturers of demineralized freeze-dry bone are sponsoring researchers in this area so that they can find more osteoinductive effect in demineralized freeze-dry bone. they are never osteogenic. Next. The alloplast. Let me tell you about alloplast. Alloplast could be from the natural source or from synthetic source. The alloplasts from natural source are called xenografts. And in fact, they're getting them from all sources now, including fish. So I'm very used to those from cow and pigs, horses, and recently my colleague here, Amin, says to me that, he has those from fish. Now, let us do some calculation. The characteristic of bony defect to be restored must be considered in determining what type of graft material that one should use. Next. The larger the defect, the more the need for autogenous bone graft. You see, I'm not a child, and I cannot play a fool or child's play with a patient. If the bone grafting area is so large, then I have to look at the patient in the face and say, the only way I can do this for you in your mouth is I have to take a big chunk of your hip bone, or I have to go to your fibula and take your bone. And I'm not going to depend on any synthetic thing to form bone for you, because I'm not doing your surgery because chances of failure or chances of success. I want success. And if I know that something is not going to give me 90-95% success, I'm not going to offer it to you. So we have to go for autogenous bone graft. Now, for small defects and for those with 3 or 5 bony walls, which I'm going to explain to you, still intact, you can use alloplast. And this alloplast may be used alone or with allograft. So that, let me not condemn allograft completely. You can mix allograft with synthetic bone grafting material. You can mix allograft with autogenous bone graft. And you can mix it with any other bone grafting substitute that has osteoinductive effect so as to enhance its bone forming activity. Next. For relatively large defects or those with only 1 or 3 bony wall intact, autogenous bone graft must be added to any other graft material. Soft tissue growth. To avoid the complication of soft tissue ingrowth during augmentation procedure with any graft material, you have to use resorbable or non-resorbable membrane. And, this now introduces you to the concept of guided tissue regeneration. Now, it is neither here nor there. I use it all the time, but sometimes when I don't have a membrane, I know what to do to simulate GTR. And although the membranes are expensive, I also have a way out to cheaper membranes, which I'm going to introduce you to during this course. Alternative membranes. Next. Thank you. Now, the next lecture is going to be very short, and then we'll take a break. Now, let us look at the types of bone grafting material. And let me be very quick to introduce you to autogenous bone graft and then discourage you quickly with regards to its use on its own. it is from another human being. All right? And they are usually banked so that, they come out as sterile product, tested product. The patient that donated it has no HIV, no viral disease, no leukemia, no nothing, right? And it is treated just the way you treat blood for blood transfusion and stored in the bank. Now, it has the benefit of avoiding a donor site morbidity. In other words, the advantage it has over autogenous bone graft is that for you to get autogenous bone graft, you have to create another surgical scar for the patient at the donor site. The examples of demineralized freeze-dry of allograft are demineralized freeze-dry bone, dynagraft, and grafton. And as people who have attended my course will tell you, during the course, I give you tips so that you can pass the exam. Even my tips, you misunderstand my tips and you still fail. So that this slide that you're looking at has quite a few exam questions, including the fact that the significant concern about this product is the perceived threat of transmission of HIV and hepatitis. Let us look at autogenous bone graft. Autogenous bone graft is the gold standard by which all bone grafting material are compared. There are various sites in the mouth where you can get them, and we call these the intraoral sites. Maxillary tuberosity, and I'm going to teach you to harvest particulate bone from the maxillary tuberosity. It's one of the simplest dental procedures that you can ever think of. Just an incision, dilation, and you scrape the bone. You don't even have to look. You scrape it. Mandibular remorse, mandibular symphysis, iliac crest, and tibial plateau, or the tibial tubercle. Let us look at the xenograft, which is part of the alloplast. The donor of the bone is a different species from the recipient. Most xenografts used in dentistry for the purpose of bone grafting are derived from bovine source, such as bios. And the recent concern of the transmission of bovine spongiform encephalopathy, which causes mad cow disease, has discouraged some clinicians from using this product. And some patients are also very reluctant to accept this product from physicians. But as I will say to the patient, the bovine source is an excellent source because it is osteoconductive and probably osteoinductive. And if their religion does not forbid them to use cow product, it is the best alternative to the animal source. I mean, to the human source. And what I also say to them is that the cows that are utilized are veterinary certified. In other words, those cows are reared and they have been tested for every disease you can think of before they use them for bone grafting material processing. And these are my favorite also. The synthetic graft. I came across the synthetic graft in 1996 when I visited Belize the first time. And when they talked to me about it and they showed me brochures and I went to my room and I read about this thing, I said, listen, I have to buy this thing. And what did I do? I went to the reception desk and I asked them if I can stay 2 days short and collect back money from my accommodation. So I use it to buy the bone grafting material, flew to Jamaica. I had patient that I would use it for, said to the patient, don't worry about money, I'll do it for you free. Because I wanted to see how it worked. And it worked real nice. And that was when I realized that the synthetic bone grafting material have substance in it. And in fact, in those days, my knowledge about bone grafting was limited and bone grafting mechanism. So that bioglass, which are bioactive glass of calcium phosphate, and perioglass, which is the same thing, are very, very useful products. This material, however, do not perform well on their own. Sometimes when the goal is implant replacement or placement. So that when you are doing implants, you have to think very well and think twice of using synthetic bone grafting material on its own. Maybe you can mix it with some autogenous bone graft. You understand what I'm saying now? Or you mix it with BioOs, which is a xenograft. However, when you mix it also with calcium phosphate, like tricalcium phosphate, they do very well. Now, today, the internet helps a lot of patients. Before they come to you for any procedure of such as implantology and bone grafting, they will check the internet for every little thing about what they're going to receive from you. And you can imagine a patient asking you, Doc, so this mad cow disease thing, how does it happen? And then you are fumbling and you can't tell your patient. So your patient may probably tell you that the disease transmission is by sub-level particles known as prions in the bovine tissue. And really, you can tell your patient that there has been no reported case of mad cow disease happening from bone grafting with bone graft substitute from bovine source. So that there is no reason for clinicians to continue to avoid using bovine source bone substitute. Next. And to round this up, and to summarize, I want you to appreciate that autogenous bone graft is the gold standard by which all other bone grafting materials are compared. Autogenous bone graft is the father of bone grafting materials. And any other bone grafting material called bone grafting substitute are second-hand bone. So I call them second-hand bone. And in fact, in the Lancet journal, that is the top journal of medicine in the 60s, from the 60s, there was an article, second-hand bone. All right? And even then, they had not done experiment to even show that second-hand bone have less osteoclastic activity and osteoblastic activity than autogenous bone. And my PhD experiment, the part one of it, actually showed that irrespective of the bone grafting material that you use, autogenous bone graft has a better osteoblastic activity. And thanks for listening. So basically we have gone through 2 lectures today. All right? And we're going to go through about 8 more before we leave. And as you see, it goes fast and smooth and you understand everything. You don't have to write because you have everything on your flash drive. When I give you hints about the exam, just write those tips down. All right? And thanks for listening.